Dear colleagues, in this presentation, in this video, I will try to explain central serous chorioretinopathy from the perspective of the Pachychoroid spectrum. Let's start with the nomenclature first. Central serous chorioretinopathy was first described in 1866 by a name we know very well, von Graefe, as recurrent central retinitis. Subsequently, the designation was altered, yet Dr. von Graefe initially had suspicions of syphilis. Then, in 1927, it was named capillary spastic central retinitis. Retinal vasospasm was suspected. Later, because of suspicions of abnormal vascular tone, it was named angiospastic retinopathy. It was first demonstrated in 1965 that the leakage in angiography was at the level of the retinal pigment epithelium. And it was suspected at that time that the choroid and the RPE were affected together. More precisely, it began to be thought of as a disease where they were affected together. These angiographic findings were further interpreted in detail by Gass, whom we know closely, and he stated that the primary pathology of the disease was in the choroid and named it idiopathic central serous chorioretinopathy. Later, Spady demonstrated the choroidal hyperpermeability in indocyanine green angiography, and the idea that the primary pathology was in the choroid has now been definitively established. The name has become central serous chorioretinopathy. However, because it is easier to say in daily practice, we often use the name central serous retinopathy. We use it. In 2008, Spade defined EDI-OCT, and with the definition of EDI-OCT, we observed that in the eyes of patients with central serous chorioretinopathy, the choroid was thick. In 2011, we also saw that the choroid of the unaffected eyes of these patients was actually thick. This indicates that choroidal thickness plays a role in predisposing to the disease, suggesting a link between choroidal thickening and the development of the condition. Finally, in 2013, the entire pachychoroid spectrum was defined along with the pachychoroid pigment epitheliopathy description by Freund. Here, Freund preferred the term patchy. Instead of saying thicking or thickened, he chose to say patchy. It's actually a word from ancient Greek, no longer used with an unknown meaning. Why did he choose this? Because the only issue here is not just the thickening of the choroid. There are some common findings in the choroid, which all the diseases in this spectrum commonly possess. Therefore, he called these pachychoroid features and defined the pachychoroid spectrum. The first diseases he defined were pachychoroid pigment epitheliopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, and polypoidal choroidal vasculopathy. Later, he himself included focal choroidal excavation and peripapillary pachychoroid syndrome in the spectrum. Finally, Saraf included the pachyvitelliform maculopathy within the spectrum. So, what are the characteristics of pachychoroid? Of course, first is choroidal thickening. We can see this as a diffuse choroidal thickening, as in this patient. Or we can see focal choroid thickening. What does focal choroid thickening mean? Here we expect the subfoveal choroid thickness to be the thickest in patients. But in some patients, for example, in this CSCR patient, the subfoveal choroid appears normal. While in other areas, the choroid being much thicker than the subfoveal choroid means focal choroidal thickening. This is our threshold for pachychoroidal pigment epitheliopathy and central serous chorioretinopathy, which we see in younger patients above 300 to 350 for subfoveal choroidal thickness. For pachychoroid neovasculopathy, polypoidal choroidal vasculopathy, and pachyvitelliform maculopathy, which appear in older patients, our threshold is 250 microns as accepted in studies. But there is no definitive value for this. Therefore, for me, other factors are more important than the thickness of the choroid, especially patchy vessels. What are patchy vessels? The dilation of the vessels in the Haller's layer. But the vessels in the Haller's layer are already wide. Look here, there is a normal Haller's layer vessel. They are already large vessels, the widest vessel of the choroid. These need to expand pathologically. How do we understand this? We notice an inner choroidal thinning just above the patchy vessels. This indicates a decrease in thickness within the sattler and choriocapillaris layers of the eye. Sometimes it thins so much that we can even measure the choroid at its normal thickness. Aside from this, one of our most important findings is the choroidal hyperpermeability shown in the indocyanine green angiography. Further additional discoveries have been included, and I will delve deeper into this topic in the upcoming parts of the video. Let's start with our first disease, pachychoroid pigment epitheliopathy. What is this? These are changes in the retinal pigment epithelium that we observe in eyes with pachychoroidal features, without subretinal fluid or a history of subretinal fluid. This is the form limited to central serous chorioretinopathy. However, it is not a sequel of central serous chorioretinopathy. Particularly in this disease, perhaps our group is the one that has conducted the most research worldwide. Initially, with 282 patients with unilateral CSCR, when we investigated the other eye, we observed the following. 61% of patients have pachychoroid pigment epitheliopathy. 31% have uncomplicated pachychoroid. What does this mean? The patient has these common choroidal features we mentioned. However, any complications have not developed. Upon comparing the outer nuclear layers of patients with pachychoroid pigment epitheliopathies to those with uncomplicated pachychoroids, we noted the following observations. The differences were evident. At the stage of pachychoroid pigment epitheliopathy, the outer nuclear layer begins to thin. This means the following. In this disease, at this stage, photoreceptor degeneration begins. Again, we examined patients with pachychoroid pigment epitheliopathy in the indocyanine green angiography and observed the following. In pachychoroid pigment epitheliopathy and central serous chorioretinopathy, there is a very high rate of choroidal hyperpermeability, exactly the same rates. In uncomplicated pachychoroids, however, this rate is much lower. There is a very significant statistical difference. This also shows us that choroidal hyperpermeability is very important in the formation of these complications. Of course, we did not decide this based solely on statistical findings. Look, the retinal pigment epithelium lesions are colocalizing here with areas of choroidal hyperpermeability at 90%, and this retinal pigment epithelial changes in the lesion, the leakage point of central serous chorioretinopathy, and macular neovascularizations show colocalization with areas of choroidal hyperpermeability. When we examined these patients' lesion characteristics and their long-term follow-ups, we saw this. We have 3 initial lesions. Microbreak, what is this? The formation of small openings where we can also see OCT among the retinal pigment epithelial cells. Pigment epithelial detachment and retinal pigment epithelial thickening. In the long-term follow-up of these lesions, we observed the following. The microbreak lesion can directly transform into central serous chorioretinopathy, or first into pigment epithelial detachment and then into central serous chorioretinopathy. When we look at the pigment epithelial detachment, we see that this lesion transforms into central serous chorioretinopathy at a rate of 11%. What I mean by transformation here is that the leakage point of central serous chorioretinopathy occurs at pigment epithelial detachment that first observed as an initial lesion, or leakage starts from microbreak that first observed. Interestingly, the other lesion, RPE thickening, it does not turn into pigment epithelial detachment or central serous chorioretinopathy. It develops into a different lesion that we call an RPE spike. And from this, later on, a regression can occur, resulting in the loss of the outer retinal layers. Here, we will see the entire process. A lesion that started as a microbreak has turned into RPE thickening. An RPE spike followed. It begins at the RPE as a sharp hyperreflective column extending towards to the outer retinal layers. Then this regresses and results in the loss of the outer retinal layers. This image made us consider this during the examination. RPE thickening is in response of the RPE aimed to prevent the occurrence of pigment epithelial detachment or central serous chorioretinopathy. What does the retinal pigment epithelium react to? Choroidal pressure. The balance between choroidal pressure and the resistance of the retinal pigment epithelium determines whether or not the patient develops CSCR, namely central serous chorioretinopathy. Our other condition is pachychoroid neovasculopathy. What is this? Type 1 macular neovascularization observed in eyes with pachychoroid features. These patients will not have drusen. There will be no other findings of age-related macular degeneration. There will be no signs or history of acute or chronic central serous chorioretinopathy. As you can see, this is a quote from Freund's first article when he described this disease. So according to this, type 1 macular neovascularizations. Secondary to long-standing chronic central serous chorioretinopathy are not pachychoroid neovasculopathy. But in an article that Freund was also involved in, they said this in a photograph. Pachychoroid neovasculopathy developing from central serous chorioretinopathy. Now, upon viewing this, then observe the following. Type 1 macular neovascularizations, secondary to central serous chorioretinopathy, may be called as pachychoroid neovasculopathy. However, there is indeed a disagreement about this in the literature. Some consider all of these as pachychoroid neovasculopathy. There are those who do not accept those secondary to CSCR. But we must know this. We truly have two distinct scenarios. One of them is pachychoroid neovasculopathy, while the other is type 1 macular neovascularizations developing secondary to central serous chorioretinopathy. In these cases, central serous chorioretinopathy indeed becomes chronic first, and as a result, a macular neovascularization forms. In the other scenario, pachychoroid pigment epitheliopathy develops first. Without any episode of central serous chorioretinopathy, a pachychoroid neovasculopathy emerges from pachychoroid pigment epitheliopathy. We also need to distinguish pachychoroid neovasculopathy from neovascular age-related macular degeneration. There will be no signs of age-related macular degeneration in the pachychoroid type. The choroid is thick. We only see type 1 macular neovascularization initially, and patients is younger. VEGF is also detected at a lower rate in the anterior chamber and vitreous. In treatment, we can use both anti-VEGF injections and photodynamic therapy. In neovascular age-related macular degeneration, we can only use antivascular endothelial growth factor. In a study we conducted earlier, when OCT angiography first emerged, we compared these two diseases. We could not detect any difference in terms of membrane morphology, lesion size, and flow area. However, in a study conducted by the Ankara University group in Turkey, major and minor criteria have been established to differentiate these two diseases. Major criteria indicate that the patient has pachychoroid neovasculopathy, the patient being under 60 years old, having a subfoveal choroidal thickness above 254 and a CVI above 72%. Not having drusen and the subfoveal choroid being thick in the other eye as well are major findings. Besides these, we also have minor findings. By considering these, we can decide whether the patient has pachychoroid neovasculopathy or neovascular age-related macular degeneration. And the other disease is polypoidal choroidal vasculopathy. This disease was first described as a red-orange nodular structure accompanying peripapillary, hemorrhagic, exudative, neurosensory retinal detachment. Januzzi is the person who gave this disease the name polypoidal choroidal vasculopathy. However, even Januzzi's having given this disease this name and no one saying anything for years actually shows how far we, as the ophthalmology community, have strayed from the general medical literature and how far we have strayed from proper nomenclature. Because the term polyp is actually used to describe lesions that form a stalked or sessile protrusion into the mucosal lumen of tissues such as the intestinal lumen or nasal mucosa. However, the expansion we are referring to here is an aneurysmal expansion, and of course it should be called an aneurysm. A group, including Januzzi, is advocating for a change in this naming, suggesting an aneurysmal type 1 macular neovascularization. They are focusing on changing the name. However, the term polyp has become so ingrained in our language and literature that changing it will be very difficult. This disease is more common among Asians. Drusen, pigmentary changes, and atrophy are relatively less common. We can observe massive hemorrhage and exudation. To be able to call a lesion polypoidal choroidal vasculopathy, we have two essential criteria. One is branching vascular network. This is a type 1 macular neovascularization. Some define this as a double layer sign, as you know. This is actually a shallow, irregular pigment epithelial detachment. However, the existence of a similar finding in this image does not indicate that the disease is PCV or that there is a macular neovascularization within it. For this to be considered PCV, there must be an aneurysmal dilation or a notched or a pointed pigment epithelial detachment at the terminal end of it. In other words, there must be a polyp. We must ensure that these elements are interconnected. They may not always be viewed in a straight horizontal line, but also in radial or segmented arrangements. They may appear in vertical sections, just like in this patient. Look, there is a branching vascular network here. At the terminal end of it, there is an aneurysmal dilation with a vertical section. And one-to-one, the indocyanine green angiography image of the patient also confirms this for us. This is a patient with polypoidal choroidal vasculopathy. Polyps do not only appear in pachychoroid patients. We also see them in age-related macular degeneration, choroidal nevi, and optic nerve melanocytomas. Therefore, Freund suggested that to differentiate these conditions, if there is a pachychoroid phenotype, we should call it polypoidal choroidal vasculopathy, or typical PCV, typical polypoidal choroidal vasculopathy. If there is no pachychoroid phenotype, and it is due to other causes, he then suggested to name it as polypoidal choroidal neovascularization. Even furthermore, in the earliest writings on pachychoroid neovascularization, attempts were made to describe these conditions by also referring to them as pachychoroid neovasculopathy with and without polyps, and pachychoroid neovascularization with polypoidal choroidal vasculopathy. Another condition is focal choroidal excavation. In this case, it is actually a concavity or deformation on the inner surface of the choroid. There will be no scleral ectasia or posterior staphyloma here. Here, the retinal pigment epithelium accompanies this lesion, either damaged or intact. If the photoreceptor layer accompanies it, we call it conforming, if not, non-conforming. It is usually asymptomatic and stable. If the lesion affects the fovea, there will be a decrease in visual acuity, of course. However, this is not a disease. This is a finding. Focal choroidal excavation can accompany all conditions that may lead to damage in the choroid. It is not actually specific to the pachychoroid spectrum. Let's move on to peripapillary pachychoroid syndrome. Here, we have three essentials. One of them is having pachychoroid features in the nasal region. The patient also has peripapillary atrophy. And we see intraretinal fluid between the optic disc and the fovea, which is what we refer to as the nasal region. There may or may not be subretinal fluid in the same area. Patients are generally elderly. It is usually bilateral. The axial length is short. We can see choroidal folds. To the condition, type 1 macular neovascularization or a polyp may accompany in the later stages. Furthermore, in this case, we will not see the appearance of cystoid macular edema on fundus fluorescein angiography. Here you can see that in the indocyanine green angiography of this patient, there is choroidal hyperpermeability in the nasal region. In the corresponding area, the choroid has thickened patchy vessels. Again, in the same area, intraretinal fluid has developed. Therefore, when we look at the fluorescein angiography, there is peripapillary atrophy in this area. We also see peripapillary atrophy on the OCT. Actually, the mechanism of this disease is very simple. In the area with peripapillary atrophy, there is no photoreceptor layer, there is no external limiting membrane, retinal pigment epithelium is absent here. The mechanism here is that due to choroidal hyperpermeability in the nasal region, fluid can now pass directly into the intraretinal space without encountering any resistance. This is actually not much different from CSCR. We have always advocated this. In fact, recent publications have started to mention this. Peripapillary pachychoroid syndrome is a specific type of central serous chorioretinopathy. Let's look at pachyvitelliform maculopathy. Here, our patient will be over 60 years old. There will be pachychoroid features. We'll have an acquired vitelliform lesion. However, there will be no subretinal fluid, intraretinal fluid, or macular neovascularization. In other words, it is not associated with the other diseases in the spectrum. It is not the accumulation of vitelliform material. This is a separate entity. Our main disease is central serous chorioretinopathy. So, what is this? In eyes with pachychoroidal features, it is a chorioretinopathy characterized by serous retinal detachment, frequently accompanied by pigment epithelial detachment. It may be accompanied by changes in the retinal pigment epithelium. There may be intraretinal fluid. It can be complicated by macular neovascularization. Vitelliform material or fibrin may accumulate. In short, the prototype disease of the pachychoroid spectrum is central serous chorioretinopathy. Let's take another look at the terminology. Here, I am drawing directly over the focal choroidal excavation. Polypoidal choroidal vasculopathy, as I mentioned. There are even papers where it is referred to as pachychoroid neovasculopathy with polyp. When we look at it this way, we see that the name pachychoroid appears in all of them. It only doesn't appear in central serous chorioretinopathy, and this disease is the only part of the name that hasn't changed since it was first defined is the central part. However, we know this. In central serous chorioretinopathy, the fluid is not only within the macula. Fluid can also start from the periphery, or the fluid that starts in the macula can spread to the periphery. But the main primary pathology is not only in the central choroid, the entire choroid between the vortex veins is affected in these patients. That's why we wrote a paper with our colleagues suggesting that the name of this disease be changed to Pachychoroid Spectrum, and this was accepted in the Retina journal. The part here about chorioretinopathy, that is, the part of the disease originating from the choroid, we already determined by starting with the pachychoroid. The basic pathology is in the choroid, and these patients have pachychoroid features. Serous retinopathy, on the other hand, shows us what the complication arising from the pachychoroid is.
Hello, colleagues. I am Dr. Furkan Kirik. I am here as the technical editor of the Vitreoretinal information sharing platform, Retina.org. In this video, Dr. Guray Ersoz gave you general information about the definition of central serous chorioretinopathy. We will soon share other videos with you regarding the classification, imaging features, and treatment of central serous chorioretinopathy. Our lecture archive will be expanded by expert ophthalmologists. You can visit our website, Retina.org, for other vitreoretinal diseases and surgical treatments. Have a good day.